So, hi guys, today we are here to talk to you about the damage control surgery. Okay, so that's what we're going to talk about. Now, what is this damage control surgery? What damage are you really trying to prevent? Okay, so first let's have a one-to-one talk and then we'll go through these slides. That's all fine. Now, what do you understand by damage control surgery, right? So, damage control surgery is like that. Okay, now let's take an example. There's a patient with a polytrauma who has come to you after the road traffic accident, and the patient is basically suffering from femur fracture. The patient is basically having a bowel injury. The patient is having injury to the, let's say there is a rent in the mesenteric vessel. And at the same time, the patient is also having a pancreatic neck injury, which the involvement of the ducts or something like that. Okay. Now, when you operate on this particular patient, all these particular things, if you wish to operate on the same go, it's going to take you a good amount of time. The surgery will last for, let's say, around 6 or 8 hours, 9 hours, or something like that, right? Now, what we need to understand is that these particular patients are already not in the best of their physiological setup, right? They have already lost their blood. Already their sympathetic system is kind of very high. And yeah, like the patients are not in the physiological homeostasis kind of a state. Now, if at all we operate on these particular patients for a prolonged period of time, the physiological status of this particular patient is deteriorating even further. Okay. And even though we have done a fantastic surgery in them, the outcomes might not be that great because the patients were not in a physiological state to accept this particular surgery or to adopt this particular surgery or something like that. You understand my point? So this is where the concept of a damage control surgery came into. Now, what is this damage control surgery? Damage control or a damage limitation surgery is a concept that originated from the naval architecture, where the ship was the kind of designed to have an areas sealed off in the case of a damage or to limit the flooding. So what you need to understand is that from where does this particular concept came in? Okay, for example, let's say there's a ship which let's say hit an iceberg. Okay, now if at all the water starts filling into that particular ship, you can cut off one particular part of the ship. You can completely seal it. If at all you seal it, then the rest of the ship will not get kind of sunk. You understand my point? So you're limiting this particular damage, you're limiting this particular damage happen to that particular ship. So this is where the concept came into. Now, how do we do this particular damage control surgery in the real life? We will talk about it, but just give me like some time. Okay, right. So what are we doing in this? What are we doing? So damage control surgery is defined as the rapid initial control of hemorrhage and contamination, because these are the two things which are really harmful for the patient, right? Hemorrhage, if at all, let's say there is some vessel which is continuing to bleed. If at all it continues to bleed, what's going to happen? There's going to be hemorrhage. Because of the hemorrhage, the patients may die. There can be exsanguination and the patients may die because of that. You understand my point? So what we are trying to do, we are basically trying to limit this particular damage which is happening to that particular we're trying to limit the damage which is basically which might happen because of what you would call as hemorrhage. Okay, so because of the hemorrhage, whatever was the damage which was supposed to happen, you're trying to kind of limit that particular thing up. Okay, that is the first thing. What is the second thing? Second thing is the contamination. So let's say if at all there is a bowel perforation which has taken place. Okay, so let's say the bowel has got perforation. Now, if at all there is a bowel perforation which has taken place, and if at all the contamination continues for a prolonged period of time, what is going to happen? There's going to be sepsis. Okay, and the patients are going to have sepsis. The patients are going to have an uncontrolled infection. So it is very, very empirical for you to kind of control that particular damage as soon as possible. So these are the two things. Okay. So how do you can do that? By, let's say, packing and temporary closure. So for example, when we come across a patient with a liver trauma, what do? We basically, what we call as, we basically pack the liver with the mox. Okay, so there are 4 P's of the management of the kind of liver. What are these particular 4 P's? Can anybody tell? So the 4 P's are basically push. You basically push the lobes of the liver together. Then there is something which is in the portal vein so that the bleeding is a bit limited. And then finally, what we have is a plug. So you pass a balloon and inflate that balloon in order to plug that particular liver trauma. You understand my point? So the two things, the primary two things in the damage control surgery is control of the hemorrhage and control of the contamination. Okay, with packing or the temporary closure and all those things. Followed by, after that, once you have done that, now the patient is safe. The patient is not going to die now. hopefully, patient is not going to die in the immediate way, like because of the sepsis or because of the bleeding. Now, what you do, you shift the patients to the ICU. Okay, you shift the patients to the ICU, and in the ICU, you resuscitate the patients. Now, why do you resuscitate the patients? Because you want to address something which is called as the deadly lethal triad. Now, what is this particular deadly lethal triad? It consists of three things. What are these three things? Hypothermia, then hypercoagulability, and so you have hypothermia, you have hypercoagulability, and you have a hypertension. So and metabolic acidosis. Okay, so hypothermia, hypercoagulability, and the metabolic acidosis. So what we have figured out that the three main things which are responsible for the death of the patients in such scenario are hypothermia, hypercoagulable state, and the metabolic acidosis. So we basically try to manage these things in the ICU. Okay, and when the patient is stable, let's say after 24 hours or 36 hours or something, when you have managed this, now you take the patients back to the OT, and then you do the definite repair of whatever the thing is. Once the normal physiology has been restored. I understand my point. So this particular slide is basically summing up what is the damage control surgery. So what is the damage control surgery? We first take control of the contamination and we control the hemorrhage by, let's say, putting a compression and doing a temporary closure of the abdomen. After that, we shift the patients to the ICU. In the ICU, we focus on three things. We try to kind of resuscitate the patient, and we try to kind of address the hypothermia, the hypercoagulable state, and the metabolic acidosis. So this is what is a deadly lethal triad. We kind of focus on this. And then once the patient is stable, where once the patient has reached the normal physiological state, now we shift the patients back to the ICU, like the operating room, and then we do the definitive repair. So this is what is referred to as your damage control surgery. This is the crux of the damage control surgery. Now, let's go ahead. So the surgery is kind of restricted to only two goals: stopping of the active bleeding and control of the any contamination. So you're not interested in, let's say, doing a Whipple surgery if at all there is injury to the duodenum and the pancreas at the same time. Okay, so what is the management if at all there's a injury to the pancreatic head and the duodenum? What is the management? We saw that in the last section, in the last lecture which we took. The management is a Whipple's procedure. But when the patient is coming to with an acute trauma, polytrauma, a lot of bleeding has happened, we will not focus on doing a Whipple's procedure. We will just do the drainage. We will just drain the proximal part of it. Let's say we'll drain the stomach, we'll drain the duodenum, and then we'll just control that particular stuff. You understand my point? So our main aim is control of the bleeding, control of the contamination. Okay, the operation is then suspended, and then we temporarily close the abdomen. Okay, so we don't do the proper closure of the abdomen layer by layer by. We temporarily close the abdomen. The patient is resuscitation continues into the intensive care unit, and once the physiology has been kind of corrected, now you shift the patients back and do the definitive surgery. That is what we kind of looked at. Okay, now what are the what you call as the key physiology of the damage control surgery to keep the patient alive at any cost? That's fine. Abbreviated surgical technique. So abbreviated surgical technique means you don't do the definitive repair, you just do what is essential to limit the depletion of the physiological reserve and to be a part of a resuscitation process. Okay, so that is what is the physiology of your damage control. So how the patient moves? Patient is coming to the emergency room. From the emergency room, you take the patients to the operating room. In the operating room, what you do? You control the bleeding, you control the contamination. After that, you do the temporary closure of the abdomen. You shift the patients to the ICU. In the ICU, what you're doing? You're taking care of the deadly lethal triad. So you're basically taking care of your hypercoagulable state, metabolic acidosis, and metabolic acidosis, hypercoagulable state, and hypothermia. After this particular thing has been what you call as taken care of, you shift the patients back to the operating room where you operate, and then you basically shift the patients back to the ICU for the post-operative management of all these things. Okay, right. Now, the multiple trauma patients are more likely to die from their intraoperative metabolic failure rather than the failure of the complete operative repair. Sorry for this particular font issue. I mean, there's some kind of font issues there. As I'm trying to tell you, that the patients might die because of your surgery, because of your prolonged surgery, not because of the trauma. You understand my point? So this is what the line is trying to sell. It's a very, very important line. The multiple trauma patients are more likely to die from their intraoperative metabolic failure rather than failure of the complete operative repairs. You understand my point? So even if you don't do the ripples at that point, it's okay. The patients might not die because of that. But if at all you do a prolonged surgery and the metabolism, like the physiological state of the patient is hampered, then the patients might die because of that. So what is this particular deadly lethal triad? It is hypothermia, acidosis, and hypercoagulable state. So these are the components of your deadly lethal triad. Okay, we've talked about that. Now, what does the hypothermia do? So let's